Welcome to Healthcare Blind Spots. I'm Vivian Kopsinger-Birchall, your host, and my special guest is Dr. Sandy Dawsey. Doctor, welcome to the show. Dr. Sandy is a pathologist and research scientist whose main interest is the prevention and control of esophageal squamous cell cancer. And during his 36 years at the National Cancer Institute, he performed multiple studies in China, Iran, Brazil, and Kenya to understand the causes of this cancer in high-risk populations and to develop clinically useful early detection and treatment techniques for this disease. Most recently, he has worked with colleagues from multiple institutions in Eastern and Southern Africa to build the African Esophageal Cancer Consortium to perform coordinated etiologic early detection and treatment and palliation studies to try to reduce the burden of esophageal cancer in this high-risk region. And needless to say, Dr. Dawsey is a Harvard graduate with Harvard College and Stanford alumni, Stanford Medical School. He did his residency in pathology at the University of Colorado, and he is a pathologist at McCormick Hospital in Chiang Mai, Thailand. And he's been a research scientist at the National Cancer Institute since 1987 to 2023 when he retired. So again, Dr. Sandy, it is so exciting to have you here to chat about your work. But to kick us off, my first question to you is what led you to focus your career on this esophageal squamous cell carcinoma? Let's take it off.
Thank you, Vivian. Thank you for interviewing me. I started out, as you mentioned, I did a pathology residency, finished in 1981, and I wanted to do some kind of service work like Peace Corps. So I called the Peace Corps. They didn't want a pathologist. I called various different societies. They couldn't find a place for me. So I called about 30 private hospitals in developing countries and got back about 15 positive responses. But some of them said, we'd love to have you come as long as you can do C-sections on the side. Or we'd love to have you come, but we don't have electricity. So if you bring one of those microscopes that has a mirror on it and you can catch the sun, maybe you can look at the slides. So anyway, my wife and I ended up going to Chiang Mai, Thailand, in the north of Thailand, and I was the first pathologist at a 300-bed hospital, 100-year-old hospital, and set up the anatomic pathology and diagnostic service there. In that 2 years, the main thing we saw was cervical cancer because that's very common in Thailand. And this really got me interested in cancer control in developing countries. So when I came back, I tried to develop a collaboration between a US and a Thai university to try to figure out how you could do Pap screening in very low resource settings. I could not get a US university that was interested in this. They thought this was not science, because Pap screening had already been proven. So but in 1987, I found an opportunity at NCI. They were looking for a pathologist to work on a large study they had just started in China, and they needed to find someone who would be willing to work in a developing country. Well, that was me. So at this point, I'm going to go back a little in history, in the history in China. In the 1940s, the Chinese Communist Party was fighting with the nationalists, the Kuomintang, and also with the Japanese. And their stronghold was mainly in the mountains, in the Taihang Mountains, which is a large mountain chain that stretches from just south of Beijing on to the southwest. And one of their generals, Deng Xiaoping, his headquarters was in a place called Linshan. Linshan means forest county. It was a very dry place, very poor place. The people lived on corn, wheat, and persimmons. and that was all they had to eat. And about 20% of them died of esophageal cancer.
Hmm.
Well, this was very impressive to Deng and to his colleagues. So in 1949, the People's Republic of China was founded. And in 10 years later, in 1959, they set up a field station in Linshen, this place that they knew very well, to try to figure out the causes and how to prevent esophageal cancer. So they were giving back to the people who had sheltered them during the war. In 1965, they also, in Linshen, they built the Red Flag Canal, which was part of the Great Leap Forward. And it was a massive hundreds of thousands of people with pickaxes and shovels dug a canal, dug a tunnel through the mountains, and diverted a river from the next province over. And they spread it out in an irrigation channels to make this a more livable place. It was one of the things that the Chinese brought guests from, especially from Africa, presidents from Africa, to see what people could do with few resources, but with strong will. And the all of this activity before we ever got there, it is a lot of it is shown in a film that you can see on YouTube called The Cancer Detectives of Linshen, Linxian. And it was a BBC production, and it was one of the very first things shown on the PBS series Nova. So if you go to Nova website and put in Cancer Detectives of Linshen, you will get right to it. And you can see how they tried to figure out what the causes were, how they they started the first early detection techniques by people swallowing a balloon with a mesh net over it and then pumping air into the balloon when it got into the stomach and then pulling it back up, scraping the esophagus for cells. So it was like a pap smear of the esophagus. And they started this back in the mid 60s. In 1972, Nixon went to China, and we were trying to find out ways that the Chinese and the Americans could start working together. And science and medicine were easy ways to start. So in 1975, the cancer people in China published an atlas of cancer mortality in which they sent 600,000 people all throughout China and found out why people died and what cancers they died from. And then they made this into maps, and you could see geographically where the high risk areas of esophagus cancer or gastric cancer or colon cancer were. This was very fascinating to epidemiologists all over the world. Um, in 1981, two British epidemiologists, Richard Dahl and Richard Pito, wrote a little book called The Causes of Cancer. And they claimed that 35% of cancer was caused by diet. And this was exactly what the Chinese thought was going on in Linshen, that the terrible diet they had always had made them vitamin and mineral deficient, and that this was causing the cancer. So this was something that the people at NCI and the people in Beijing could both get excited about, that they would try to give people vitamin and mineral supplements for like 5 years, daily supplements, and see if they could reduce these terrible rates of esophageal cancer. Fred Lee, who was an NCI scientist, who was the Lee in the Lee-Fraumeni syndrome, went to Beijing. He was Chinese. His wife was Chinese. They met with Zhou Enlai's wife and people very high in the government, and they agreed to do this collaboration. So in 1985, the nutrition intervention trials began, and in 1987, I joined this. Now, to step back for a second, I'm going to tell you a little about esophageal cancer. It's the seventh leading cause of cancer death in the world, and it kills about 500,000 people a year. There are two kinds of esophageal cancer that are really two totally different diseases that are in the same organ. One kind is adenocarcinoma, which is what is most common in North America and Western Europe. It's about 15% of esophageal cancer worldwide. It's caused by gastroesophageal reflux, which changes the mucosa of the esophagus, of the lower esophagus, into a glandular epithelium instead of a squamous epithelium. And so most of the cancers are in the lower third of the esophagus. The other kind of esophageal cancer is esophageal squamous cell cancer, or ESCC. That is what is most common in the rest of the world. It's about 85% of all esophageal cancers. It's mainly caused by smoking and drinking, at least in the West, and it can involve any part of the esophagus. They're similar clinically, but they have different risk factors, and they really are different diseases. Now, clinically, esophageal cancer is a terrible disease because the symptoms occur very late after the tumor usually has already spread. And the reason is that the esophagus has a muscular coat, and it can expand to let food go down and can contract. And so you don't feel difficulty swallowing, which is the usual first symptom, until the tumor is almost completely occluding the esophagus. So it is completely surrounding, and so the esophagus, so it cannot expand, or there's a big mass in the middle of the lumen. And by that time, when you first have difficulty swallowing, the tumor has usually already spread outside the wall of the esophagus. So in both kinds of esophageal cancer, this usual survival is only about 3 to 6 months. Now, there are ways to treat it that can actually cure it, but you really need to catch it early. So this means if we're going to reduce the burden of esophageal cancer in the world, we really need to concentrate on prevention or early detection. And then you can also help it by getting better treatments, and then by palliation, which helps the quality of life but doesn't extend the lifespan. There are two main areas in the world of very high risk for esophageal cancer. One of these is across Central Asia, starting at the Caspian Sea, going over to northern China, and that's Linchen is part of that. The other is down the east coast of Africa, essentially following the Rift Valley, going from like Ethiopia all the way down to the eastern half of South Africa. And in these bands, the incidence is about 10 to 50 times what it is outside these bands. And sometimes over 200 kilometers range, you can change the rate of the esophageal cancer by 10 times, which is just amazing. This means it's probably not primarily a genetic disease, because you have people, Chinese people, Iranians, Africans, all having this really terrible disease. And then you have people of the same racial makeup 200 kilometers away not being affected. So it's almost surely mainly environmental.
Some of the statistics that you have, or the information that you've given, is very eye-opening. First of all, being from East Africa, mentioning that belt, we fall under that category, and the similarities with what you've seen in China and Iran. In your perspective, what makes this cancer particularly important from a global health perspective, given that kind of history? And then perhaps we'll then get into the causes and interventions.
Well, I think it's from a global health perspective, it's an extremely important cancer because it's the seventh most common cause of cancer death. It kills 500,000 people every year. And in these high risk areas, it's one of the top three cancer killers, and usually in both sexes, in both men and women. So in Uganda, for example, it's the second most common cause of cancer death in men and also in women. And so this makes it very important for the healthcare for healthcare in those regions.
Yeah, it's great that you mentioned that it affects both men and women. Well, it's not great, but it's important that we understand that. And maybe as we're talking about these demographics, what have you observed among children? Does it also affect children, and in what trend? What's the trend?
Most areas in the world, in the high and low risk areas, the average age for somebody getting this cancer is in the late 50s or 60s or even the low 70s. So it's sort of an older adult disease. In the African area, though, this is quite unique. They have about 25% of the people who come in with this disease are under the age of 45. That's compared to 2% in the US. And uh, the one hospital that we worked at in Kenya and really looked into the statistics, about 18% were under the age of 40, about 8% were under the age of 30, and there were scattering of cases that were in their teens, in their teenage years. And you don't see this anywhere else in the world. So there's something different about what's going on in Africa compared to China or the US or any of these other places.
Well, and it would be interesting to know, what research is finding out regarding that, and which ties into the question I heard also for you, is as you've worked in all these different countries, what are what factors have you identified that differentiates all the risk factors in these different regions?
Well, make to make the answer short, um, the we found out in these randomized clinical trials in China, uh, giving people different groups of vitamins and minerals, that the people who got selenium, a combination of selenium, beta carotene, and vitamin E, they had a reduction in total mortality, significant reduction in cancer mortality and in gastric cancer mortality. And at the end of the 5 years, the esophageal cancer mortality, they had a small reduction, but it was not significant. But what was amazing was after we followed these people for 10 years after the end of giving them the pills, meaning 15 years after they started the pills, we stratified this by age when they started the pills, when they started the intervention. And the people who started getting this selenium, vitamin E, and beta carotene pills, if they started below the median age, below 55, they had significant protection. But if they were above 55, they had significant risk, increased risk.
Yeah.
And so it was as though the vitamins were protecting against the development of the disease, but once it got to a certain point, they were feeding the disease. So you had to start doing this intervention early. Other things besides diet, and in this case, it turned out that selenium was the active ingredient in that combination. And if you look at soil selenium maps in China and compare them to the esophageal cancer maps, they're not exactly the same, but they're very suggestive that when you have low selenium in the soil, um, then you end up with low selenium in the plants and in the animals. And people that eat local produce, they end up having low selenium in their blood. And this low selenium is related to their risk of esophageal cancer. It increases their risk of esophageal cancer. So that's one thing. Now, other things we found in China, um, you would go into the houses and you would see in the kitchen that the walls were completely black. And this is because they were burning coal for heating and cooking. And they were in unventilated rooms and they didn't have chimneys. And so there was smoke in the room, and you could go with your finger and you would just scrape off soot off the walls. Um, and then we being pathologists, we did some examination of like esophagectomy specimens, and we found uh, really black lymph nodes on the outside of the esophagus. They were looked like smokers' lymph nodes around their lungs, but these people were not smokers. And so we thought somehow they're being exposed to the same kind of thing that you get when you smoke cigarettes. And it seemed to be from the kitchens. And then we tested their urine and found that there are metabolites of a compound called polycyclic aromatic hydrocarbons, or PAHs. That's one of the main carcinogens in cigarettes. And we found that the people, the non-smokers in Linshen, had 14 times as high levels of these metabolites as non-smokers in the US. So they were clearly exposed to carcinogens, and we think it's because of this smoky indoor air pollution. So that's a second risk factor. A third one was really came from our studies in Iran, and this was about hot temperature drinks, beverages, and food like porridge. Um, and there had been, since the 70s, there had been descriptions of people that drank their tea or coffee very hot having a higher risk of esophageal cancer. But exactly, you got to watch it. Uh, but 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 it was what is hot? So you would ask people, do you drink your tea warm, hot, very hot? And the people that said very hot, they had a higher risk. But nobody ever measured the temperature. So in Iran, where we had people coming in for interviews for in a cohort study or a case control study, we had a samovar and we had boiling water. We made the tea and we put it into two cups. And one cup we presented to the person being interviewed, and the other cup we had behind a screen with a thermometer in it. And we'd say, is this how you drink your tea? Oh, no, 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 that's too hot, too hot. And then a minute later, is this how you drink your tea? And when they finally said, yeah, that's how I drink my tea, we would look at the temperature. And with this, we found that people who had uh, 60 below of 60 degrees centigrade or below had no increased risk. People that had 65 degrees, about 65 degrees, had a twofold risk. People who had 70 degrees had an eightfold risk. And this was the first study that showed this in a actually measuring the temperature. And this made it is now the people at the International Agency for Research on Cancer in Lyon, France, which is the World Health Organization cancer research arm. They came out saying that anybody drinking their tea or coffee of above 65 degrees, that this was carcinogenic, presumably because it thermally it hurts the esophagus by heating, and then other carcinogens can get into the mucosa. We don't know what it is, but it's a very consistent finding. So hot drinks is another risk factor. Then in China and then in um, in Kenya, we found that um, poor oral health is related to esophageal cancer. And this, at first, in the first study in China, they counted the teeth in 30,000 people in this uh, trial, and they found that the more teeth you had lost, uh, the higher your rate of cancer, until you became edentulous, meaning you had no teeth. And then your risk went back down. And that has been associated, we think that the association is with the oral microbiome, the bacteria that live in your mouth. Because when you have tooth decay or when you have gum disease, periodontal disease, the bacteria in your mouth change. And that we think that that is what is related to the cancer. But it's been shown in multiple studies all over the world that poor oral health is related to esophageal cancer. So at least the low selenium in your blood, indoor air pollution, which is like smoking cigarettes, uh, or hot drinks and hot food, hot temperature food, and poor oral health are things that seem to be universal risk factors, along with smoking and drinking alcohol, which are everywhere. Yeah.
Right. I'm now very curious about, especially the East and Southern African belt, whether there's been any specific clinical trials in that area, or very specific studies that are unique to that area and what the findings have been.
Well, we'll get to Africa or the African Esophageal Cancer Consortium in a little bit,
Yeah.
but in with that group, which is trying to do collaborative etiologic and early detection and palliation studies in this Eastern and Southern African region, we've done 7 case control studies now in various different 4 different countries. This is where you look at people who have the cancer and people that are similar from a similar background, from a similar area that don't have the um, cancer, and you give them questionnaires and you take blood and urine and measure things in those fluids, and you try to see what is different about them. So it's cases versus non-cases or controls. And in those studies, these are the main factors that we have found. The hot drinks, the poor oral health, the indoor air pollution. In Africa, it's not coal that's making the smoke. It's wood. They're wood fires, but they are in uh, poorly ventilated kitchens, and they don't have chimneys. And when people like us that are not used to the smoky environment go into these kitchens, you can't stand it. You're just coughing immediately. And the women live in this smoky environment like 8 hours a day. They're either cooking or tending the fire. Also, their little children are with them. They're either on their back, they're running around, and so forth and so on. And this is one huge exposure that we think may be causing the young cases that are seen there, because the children are getting this huge exposure from birth. And so we're studying that now to try to prove it. But you can imagine there are interventions that can be done, like education, to tell people that you need more ventilation and keep the windows open, make more windows, trying different cook stoves that will have a chimney or a way for the smoke to get out. So there are interventions that you can think of to try to decrease this.
This is exciting, and I think we're going to get into Afrek's work since we're already talking about Africa. because even as you're talking, the question that comes to my mind is, have any studies been done with the soil sampling? Because you mentioned soil in China, do we have, similar factors?
Yeah, this is very, very interesting. There have not been systematic soil sampling like there has been in China, but they people, if they look at what minerals and vitamins are in the foods and what foods are eaten, and they call it food disappearance rates of these vitamins and minerals. They can get an idea of what people are eating and consuming. There is the band of low selenium in the diet looks just like the band of esophageal cancer. And another thing that has been found and again, only in these African studies, when people, because of the poor oral hygiene hypothesis, people have been looking carefully at people's teeth. And there are a lot of people in this region that have these brown stains on their teeth, these usually horizontal brown stains on their teeth. And that comes from fluorosis, which is too much fluoride in the water when the permanent teeth come in. It only matters when the permanent teeth come in. But it is known that from valley to valley, you can have different amounts of fluoride in the water, and fluoride also comes from the soil. Okay. And so when we first went to this Tenwick Hospital in Bomet, Kenya, Western Kenya, we asked the people in the endoscopy room and everybody around, what's causing this cancer? And half of the people said, it's the people with the brown teeth. And the other half said, no, no, they're the ones that don't get the cancer. It's the people with the white teeth. So people had noticed that there might be a difference. And we found that this was having these brown teeth, having fluorosis was a very big risk factor. So, and if you look at water maps of Africa, and you see where the high fluoride levels are, they are also in this same high risk esophageal cancer area up and down the East Coast. So there's a theory, and it has not been proven. But when you ask, what is the difference? I mean, what about the rest of Africa? Do they have smoky kitchens? Well, yes. And do they drink their tea hot? Well, yes. Okay. Do they not brush their teeth quite as much? Maybe. But what they don't have is this low selenium and high fluoride. And this it makes you, it's called geochemistry. It's the chemistry of the soil. And what the Rift Valley is, it's a geological plate that's pulling apart. Okay, it's pulling apart. And so it means that rock from underneath is now at the surface. So you get different rock, different soil, and different mineral content in this area than you do in the other areas. And this is not proven, but it is one thing that's very different about this band of high risk.
Well, lots of questions, lots of, but let's first get into Africa. How did you come about this idea of putting together this consortium, and what is Africa doing? What's the goal? What's the vision?
Well, Africa, it started with a conference at NCI. That once a year, NCI and IARC, this group from the World Health Organization, they get together and they try to talk about what is the current state of science around a certain cancer and what can be done next and what should priorities be. And so in 2016, this conference was about esophageal squamous cell carcinoma. And people brought in, data from Europe, data from the US, data from Asia, but there was almost no data from Africa. and yet everybody knew the rates were high. And there were quite a few African experts at the conference, and most of the discussion was about Africa, that it was not well studied, that a lot needed to be done, that the early detection work that had been done in China had not been done there. And so we people who were interested in or had actually done work in Africa um, decided to start a consortium, a group of research sites and scientists and clinicians from these areas in Eastern and Southern Africa. And this started in 2017, and we called it the African Esophageal Cancer Consortium. And getting an acronym, it was AFRECC, which we call AFREC. The vision of AFREC is to end suffering from esophageal cancer in Africa. That's the vision. The mission is to decrease the burden of esophageal cancer in Africa through collaborative research, prevention, education, and clinical care. And at this point, we have 14 collaborating sites in 8 countries. We have about 150 members from about 20 countries. About 85% of them are from Africa. We have bi-monthly conference calls for all members and for what we call the etiologic working group, that are mainly people interested in risk factors and why they're getting this cancer, and the clinical working group, which is mainly interested in early detection, treatment, palliation, what we can do clinically. As I said, we've done these 7 case control studies that we are now combining. We've published the individual results, but we're now combining the data from all these countries to see what is different, what is the same in different countries. We're doing a genome-wide association study, which is a genetic study that you can do on blood to look at the DNA of people that have the cancer, people that don't have the cancer, all up and down the coast. Then on the clinical side, we've done an endoscopic capacity survey, which shows the great need for doctors that work in this area, for equipment, endoscopes, things that you can look inside the esophagus, for all sorts of resources. We've done some preliminary early detection studies, but our main thing clinically has been the Stent Access Initiative. And this is because virtually all patients in Africa come in at very late stage. They cannot swallow food, they cannot swallow water, most of them cannot swallow their own saliva. So they come into the clinician and they are frail, they've lost weight, and they're carrying a cup or a bag that they're drooling into, they're spitting into. They can't swallow their saliva. And this is very embarrassing. It's not, you're not, don't feel very dignified. So we will not be able to cure these people, but we can give them a better quality of life. And what you can do is you can put in an esophageal stent, which is a metal mesh that has been squeezed down into a delivery device. And so you can go in with the endoscope and you can put dilators to gradually get, if you can pass even a wire, guide wire through the tumor, you can then gradually open the tumor up until you can put this stent in. And when the stent opens, it pops open, and you have about a centimeter in diameter lumen that you can then swallow food, you can swallow water, you swallow your saliva. You feel much more dignified. You can live the rest of your life without, so that you can see your friends, you can say goodbye, you can, live in society. So this is totally, it's palliation. It's not cure. But it's something that is a tremendous help for both the patients and the doctors because there's something they can do now. Um, so on the clinical side, we've mainly been doing workshops where we train people to put in these stents. Our main collaborator in this, and we couldn't do it without them, is Boston Scientific Corporation, who makes stents, and they have agreed to donate quite a few stents and sell other stents at a much reduced rate that some people can afford. Um, and they have helped put on these workshops. The other group that has really been helping us recently is Olympus Corporation, which makes a lot of endoscopes, and they have given us a grant to put on about 10 of these workshops in this year and next year. So without the help from the industry, we couldn't be doing this, but we are training um, these doctors to put in these stents.
Right. Again, amazing work. I'm so proud of the work of what you did, putting all this together, putting AFREC together. Not I think, the service that you're providing is there. You can't put a value to it because you're training, you're building capacity in the region. And I guess in that regard, I wanted to uh, ask about the vision and legacy for AFREC. What do we want to see? What's our wish list? What's the wish list for AFREC when it comes to providing these interventions? And how can they be scaled? Because the need is huge.
Well, I'll tell you, there's one thing that we haven't talked about that I need to talk about before answering that, and that is efforts to do early detection.
Mm,
Because the only ways that you're really going to reduce the mortality from this disease is either by finding out what risk factors are there and finding ways to reduce those risk factors and therefore prevent the development of the disease in the first place, or early detection where you can find tumors when they're in the precursor stage. I mean, they're not really invasive yet. They're not really a cancer yet, but they're going to be. Or they're very early and you can actually treat that and cure the patient. We have to have those two aspects if we're going to really reduce the burden. So going back to China, um, when I got there, the first time I was in the field, it was completely obvious that these people needed an early detection and treatment program because they were all coming in late. They were all going to die of this disease. And it was not too dissimilar to what I had been seeing in Thailand with cervical cancer. And the Chinese had started this balloon cytology where they put the balloon down and pulled out a cell sample from the mucosa, which was very much like a pap smear. So uh, I decided, or we decided, that if you're going to have an effective um, early detection program, you need several components. You need to know what the precursor lesion is, what is your target. You need to know how do you screen for this target that is in a way that is inexpensive and that is patient acceptable and is accurate. You need to, if now that you've screened for it and your test says, oh, this person has one of these early lesions, you have to go in with endoscopy and locate this. You have to be able to localize the problem. And then you need to be able to go in and either remove that or burn it or destroy that early lesion in some way. So in China, the first thing that I did was one of my mentors and I reviewed about 5,000 slides and came up with what different categories, histologic categories we could define, and using also cervical histology, other previous studies, but we did this de novo, and we divided things up into normal esophagitis, dysplasia with different grades of dysplasia, and cancer. And then we did an endoscopic survey in 1987, and we looked at all the biopsies. We took multiple biopsies, any kind of lesion that you could see, and also some that where it looked normal, the mucosa looked normal. And we categorized those biopsies, and we said this person has dysplasia, mild dysplasia, they have severe dysplasia, other people had esophagitis. And then we followed those people and we saw who got cancer, because we did not have a treatment for these people at this point. So we followed them, and after about 13 years, it was only the people with dysplasia that got the cancer, pretty much only, not only, but that really had an increased risk compared to people who had totally normal biopsies. And you could divide them into mild, moderate, and severe dysplasia, looking through the microscope. And those had a 3 times risk compared to normal, a 10 times risk, and a 30 times risk. So they really could tell you by looking at the biopsy how much risk you had. And so we thought, okay, we know what the precursor lesion is. It's this high-grade dysplasia. So then how do you see this? We tried the balloon cytology, and it didn't correlate very well with the biopsies. So the balloon cytology didn't look very promising. But then we did the endoscopy, and at the same time, there were people in Japan and people in Europe that were using Lugol's iodine to spray. They sprayed it on the esophageal mucosa. And a normal esophagus, what Lugol's iodine, it combines with glycogen, which is a energy storage product. It's a kind of sugar that cells that are very quiet, that are not dividing rapidly, they have a lot of it. And things that are dividing quickly, they're using up all the energy that they have, and so they have very little glycogen. So the normal iodine stains things brown, and so the normal esophagus stained brown because there was lots of glycogen. The abnormal areas did not stain. We call them unstained lesions. And so they stayed sort of yellow or tan. And these were very easy to see. I took my 10-year-old son to Linchen, and he watched people doing this endoscopy. And by the second day, he said, "Hey, you should biopsy there," because he could see these lesions. Well, that's just what you want. You want something that's easy to see. And they biopsied these lesions. Well, we did a bunch of patients that had lesions, and we biopsied the lesions, and we biopsied away from the lesion in the normal staining mucosa. And we found that 96% of the high-grade dysplasia was in these lesions. That means that you could localize the dysplasia by this stain. And that means theoretically that you could go in and take out, if you biopsied it and it was high-grade dysplasia, you could go back and try to take out that piece of mucosa to cure the person. And then at the same time, or a little bit later, the Japanese especially were developing techniques to go into the esophagus, take out this little piece, and then you didn't have to do an esophagectomy. You didn't have to cut out the esophagus. You could just take out this little piece, and then they would not get sick, or they wouldn't develop the cancer. So we had this program now, this protocol, where we would take adults from these high-risk areas, and we would just endoscope all of them.
Mm.
And we would spray the spray and we would biopsy the unstained areas. And those with high-grade dysplasia, we go back and take out the lesion. And this is now a national program in China. They
Wow.
screen about 300,000 people a year. They have about 3% of the people have something that needs to be removed. So they are curing about 10,000 people a year.
Wow.
And so and they've done two studies now. These are the Chinese have. We haven't been part of this, but they've done two studies where they went into an area and they told everybody in a group of villages, if you're between 40 and 60 years old, you come to us, we give you a free endoscopy. If you've got a lesion, we will cure it. Another group of villages that they do everything the same, except that they tell them about esophageal cancer and all this, but they don't do the endoscopy. And then they compare what happens to those two groups of villages. Um, and in both of these studies, in the villages where they offered this program to the people, they reduced the rate of esophageal cancer death by 33%.
Mm.
Okay, which is really they can we endoscope you, we can find it and we can cure you. Um, and only 50% of the people in those villages agreed to be endoscoped.
Right.
So really, of the people who were endoscoped and followed the protocol, two-thirds of the deaths were uh, avoided.
Wow.
So
Amazing.
this is a system that works, okay? Um, and so it would be wonderful if we could use this all over the world.
Mhm.
But you have to have a lot of endoscopes. You have to have money to buy them. You have to train people to do this screening. You know, and even in China, with all of the resources that they have, they're only screening 10% of the people they should be. They
Mm.
should be screening 3 million people a year, and
Right.
they can't. And then when you turn to Africa, you certainly can't because you don't have the personnel, you don't have the endoscopes, you don't have the resources. So this is great, but it's not the answer because we need a primary test that you can do that's super cheap, that anybody can administer. Don't even have to be a nurse. Um, and that anybody will, it's patient acceptable, and it will say, you are at, we really think you've got this cancer, you go to endoscopy. And
Mm.
we want like 10% of the people to go to endoscopy, 90%. You've done the test, but they are negative. Okay.
Right.
So that gets us back to cytology and this balloon, or now they're making sponges. They take a sponge and they squeeze it down, a little sponge, and they put it inside a gelatin capsule and they tie a string to it. The person swallows the capsule. It's like an antibiotic pill. You wait 5 minutes while the gelatin dissolves in the stomach. The sponge comes out and you pull it up, and you have a pap smear of the esophagus. And at this point, the block that we have because these things you can make these sponges for a couple of dollars a piece. You can Anybody can learn to do it. So you don't need a highly trained healthcare worker to do it. You can go to a village and you can do everybody that's willing to do it, and then try to find who goes to endoscopy. Um, at this point, and this is the problem that we have, the main problem that we have clinically in Africa is that we do not have a test that can use those cells and accurately predict who's got the high grade dysplasia, who needs to go to endoscopy. So people are looking at DNA markers that they can amplify so that if you have even a few cells in there that have this, that they will show up on your test. They're also the Chinese have now looked at when we were doing our balloon studies, we would look at 3 or 4 smears. But we were getting 3 million cells. So we were only looking at 1, 2, 3, 5% of the cells. So of course we had terrible sampling error. And if you only had a few cells from a small lesion, you're not going to see it. And that's why we couldn't use it. But now they are putting 100% of these 3 million cells through filters. They make a monolayer on the filter. They put it in a machine with image analysis and artificial intelligence. They scan it, identify abnormal areas, and they end up with a score. And they say, you have to go to endoscopy. And they've done this on 17,000 people. And they found that if they only sent to endoscopy the positives that this AI test said were positive, they would have done only 10% of the endoscopies, but they would have found 92% of the cancers
Mm.
and early lesions. So if that works, then we could use that in Africa. So we are currently testing that in Malawi with the first study is only 1,000 people, but we're doing the sponges and we're sending this off to the Chinese algorithm and we'll see if it works.
Yeah.
So you want to know what we would like to do.
Right. And as we've come up to the hour, so
Okay.
I need to bring you back. But yeah, let's just
What we would like to do is we would like to find risk factors that we can modify by education, by rework, getting people to change the way they cook, by changing the way, waiting a few minutes before they drink their hot tea, this kind of thing. We also need to finally find a useful, inexpensive, patient acceptable um, primary screening test that we can then use for early detection. Because if we can detect the tumors early, we can cure them. And if we can do those two things, we will reduce esophageal cancer death in these high risk areas. Um, and at the same time, a lot of this has to do with advocacy and education. Educating the population. If you feel a little trouble swallowing, you go immediately to a medical doctor, not to a traditional healer. And those people send you directly to endoscopy. We need to train the medical people to say, oh, if you get this, you send them to the right place. We need to train the governments that this is a really important thing in your country, and you need to have a cancer control plan for this thing. My idea, my dream is that you could combine this sponge screening with screening for other cancers. You could have people come in and talk to them about breast cancer, how to do self-exam, have a nurse or someone feel the breast. If they find a lump, they aspirate it and they make a diagnosis early. You can do the same at the same mobile van or the same site. You can do cervical cancer screening with pap smears and HPV testing and education. You can do Kaposi sarcoma, looking at the skin, and you could do this esophageal cancer screening all together, and you could have a mobile place that went around to villages and get all of these cancers early. And I don't see why we couldn't do that.
absolutely fantastic. And yes, I know there are so many more questions I have, certainly, but because we're at the top of the hour, I just wanted to say thank you again for making the time to speak to us about esophageal cancer. And certainly, I want to bring you back because there's so many follow-up questions to some of the things you've mentioned. For example, as you know, after the screening, there's the whole question of where do they go if they're not facilities. So there is a lot. But again, Dr. Sandy, thank you for being my guest today.
Well, thank you so much for having me and for putting on these interviews and spreading the word about the different medical conditions that you do. You're doing a great service.
Thank you, thank you. And to our viewers, I hope you've learned a lot about esophageal cancer, some of the history, some of the experiences and case studies. And if you want to learn more, look out for more videos on healthcare blind spots. But for now, thank you for watching. Till
Thank
next
you.
time.